So I'm delighted to have 30 minutes to talk about granulomatous diseases of the nose. It will give me the perfect excuse to show you lots of histopathology slides and talk about pink cells for half an hour, just what you need on a Friday afternoon. You'll be glad to hear, however, that I actually know very little about histopathology. I'm just having trouble advancing my slides. And this pretty much sums up my knowledge of histopathology. A granuloma is an organised collection of macrophages containing histiocytes, multinucleate giant cells and epithelioid cells, and it should not be confused with granulation tissue. So what we typically call a granuloma, pyogenic granuloma, for example, or a vocal cord granuloma, are actually granulation tissue, and they're not true granulomas. And that's about it from the histopathology point of view. So I'm going to rename my talk as, and I don't know why we're not going to the next slide, weird, worrying, but wonderful sinonasal conditions in the nose. So our job as ENT surgeons really falls down into 5 things. And by far the most important is to make sure that we don't miss granulomatous disease. And if we do that more than anything else, we can make such a difference to these patients who typically present to ENT departments. But we're also involved with the diagnostic workup, directing patients to the right rheumatologist to manage their disease, to help the rheumatology team with monitoring disease activity, and then supporting patients both in terms of complications of disease and occasionally surgical reconstruction. And there are a number of different causes of granulomatous disease: trauma, inflammation, infection, autoimmune disease, neoplastic and substance abuse. The last two are things that we need to be excluding, and the majority of our patients will fall into the autoimmune inflammatory group of conditions. There are a whole range of infections that can cause granulomatous disease. I have never come across any of these other than TB, but if our rheumatology team and our blood tests and other investigations haven't found an inflammatory cause, then it's certainly worth getting an infectious disease specialist to review our difficult to treat patients. But again, we're going to see most of our patients falling into the group of Wegener's, or now known as GPA, because Wegener turned out to be a Nazi supporter, Sarcoidosis, Churg-Strauss, who wasn't a Nazi but has lost his eponymous syndrome and it's now called EGPA, cholesterol granulomas, eosinophilic granulomas, and then the neoplastic conditions that, as I said, we need to make sure we don't miss. And we're going to suspect them in a patient that presents with crusting, nasal obstruction, epistaxis and facial pain. They might have other ENT symptoms such as hearing loss, ear pain, facial palsy, scleritis, stridor, lethargy, arthralgia, shortness of breath. The key things really are to be suspicious when the patient doesn't respond to treatment that you would expect in the normal way, where they've had very intense scarring after surgery, or generally a patient that feels unwell. We all see patients with nasal polyps, and apart from having a blocked nose, they're able to carry on with their normal everyday life. But it's the patient, for example, with nasal polyps that really doesn't feel well, that is fatigued, that you then start to worry about conditions such as Churg-Strauss. So this, is a real giveaway that something else is going on. We might see signs of granulomatous disease, which really presents as cobblestoning in the nose, adhesions, crusting. We might see a septal perforation and saddle deformity, middle ear effusion, vocal cord thickening or subglottic stenosis, orbital mass, skin changes, and these apple jelly nodules, typically in sarcoidosis. And again, adhesions after surgery can be really intense and would be a reason to start questioning if there's something going on more than just poor surgical technique. And the key thing is to have a high index of suspicion. You've got to think about that patient who's unwell in your clinic and do something about it. That feeling that something isn't quite right, and really you can blame all of your surgical failures on the possibility of an underlying granulomatous condition. So it's the perfect excuse for a surgeon. It couldn't possibly be my fault. There must be something else going on. So, as I said, the most important thing is that we don't miss it. This lady was someone I met in my first year as a consultant, and I've got to know her very well over the last 10 years. She was referred for nasal reconstruction. And the history was that 10 years previously, she had an infection in the nose that wouldn't settle. And somehow it was decided that it would be a good idea to treat this with a septoplasty. Perhaps not surprisingly, this was then complicated by a septal perforation, progressive midline destruction, huge saddle nose, massive septal perforation. Her nose could be smelt probably from a few miles away. She had this really torrid, foul-smelling, heavy crusting in the nose. And over the course of the 10 years, her middle ear disease had got to the point where it decided she needed a Baha. And she walked into the clinic room looking like this. You can see her Baha, you can see this terrible saddle nose deformity, an over-rotated tip, complete loss of all the septal cartilage. And so I asked her, having looked in the nose and seen this, and was quite difficult to look in the nose. It really smelt quite awful. How long she'd had vagueness for, we were still allowed to call it vagueness at that point. And she looked at me quite blankly, and she'd never heard of the term vagueness or GPA. And going through the notes, it said that vagueness had been excluded 7 years previously. She'd been tested for ANCA once in her whole 10-year history. And this vagueness has been excluded was simply repeated through the notes throughout the next 7 years. So even as her nose collapsed and she had her BAHA, it wasn't questioned again because this record in the notes had sort of been pulled through. And I had never seen a better textbook picture of vagueness. And now at the time when I first met her, her ESR was raised, her CRP was raised, she was anemic, and she was anti-PR3 positive. And that's quite typical that patients don't seroconvert early on in the disease, but if you keep looking for it, eventually they will, particularly as the disease becomes more widespread. So, key points: there is no test that conclusively excludes a vasculitic or granulomatous process. You can help rule them in, so they're very useful if they're positive, but if they're negative, you've simply got to keep asking the question. And another take-home point: never operate on a crusty septum because it really will fall apart. And the septal perforations I see in clinic have often had this preceding history of crusting and bleeding long before they had any surgery. But the minute you operate on it, that septal perforation becomes your fault, even if there is an underlying condition. So be very cautious if the nose doesn't look quite right. Do nothing more than a biopsy. So GPA, granulomatous, polyangiitis, can affect any organ in the body pretty much, but typically the nose, the lung and the kidneys. So they might have septal perforations. We've seen saddle nose, rhinosinusitis. They typically have lung infiltrates. They might have kidney disease and renal failure. And this is what often kills them. It affects about 3 in 100,000 adults. And as a quick rule of thumb to help you remember, 90% are Caucasian, 90% involve the sinonasal tract, 90% are C-ANCA positive, and it has about a 90% sensitivity and specificity, with the exception of localized GPA, where only about 50% are positive, and it can be much lower early on. So you've just got to keep asking the question. In a patient with crusting, I would look for that every time: septal perforation, adhesions, all of those things. They quite often have secondary colonization with Staph aureus, so they get this heavy mucopurulent crusting in the nose. These are relatively mild cases, and you can see the mucosa just doesn't look quite right. There's this little cobblestoning edema. There's a little bit of crusting. It doesn't look terrible. Its septum's not falling apart, but you don't want to do a septoplasty on this patient because you know it won't heal well. And it's got to raise the question whether there's something else going on. You might see in a septal perforation these unhealthy edges rather than nice smooth healed edges. And it's worth biopsying the edge of a perforation when it looks like this, not worth biopsying the edge of a perforation when it's healed and looks normal. And you might see it in a patient that has failed surgery of chronic rhinosinusitis. This is a lady who had had a Lothrop procedure, revision surgery, and we still couldn't get her right. And she had this really heavy green Staph aureus slime absolutely filling her nose. Her C-ANCA was negative at all points. Her ESR and CRP were always normal, but she had tiny splinter hemorrhages in her fingers. And my rheumatologist agreed that this was probably a very localized form of vasculitis. And having treated her with methotrexate, her sinuses are now normal. So again, it's thinking about it in those cases that aren't quite right, but in some cases the diagnosis can be really obvious. So this is someone that has lost her eye from orbital pseudotumor, has middle ear disease and complete collapse of the nasal cartilages. What you can't see is she's also had tracheostomy in the past because of severe subglottic stenosis. So our job is to help with the diagnostic workup. We're going to think about blood tests. ESR and CRP are very useful. ANCA. C-ANCA is almost always positive in severe GPA, but quite commonly negative in limited disease. Anti-PR3 increases the specificity, particularly with regards to cocaine use. Cocaine can induce an ANCA-positive vasculitis, so certainly ANCA positivity doesn't exclude it to being cocaine. P-ANCA is more useful in EGPA. Serum ACE levels in sarcoidosis. I always take a urine specimen, both for looking at hematuria, but also cocaine metabolites. And check renal function, because that tends to be what kills patients quite quickly. Full blood count to look for anemia, and the eosinophil count is suspicious for eosinophilic GPA in severe nasal polyps. Pink slides again, I couldn't tell the difference, but apparently one is an NK T-cell lymphoma and one is GPA, and certainly from my perspective, they look quite similar, but fortunately our histopathologists can tell the difference. It is really only useful if you have abnormal mucosa. We're quite often asked by rheumatologists to biopsy a nose, but if it really all looks normal, you will simply get a normal report back. But if there is an area, take a deep biopsy, give the pathologist clear instructions as to what you're looking for. If they are PR3 positive, I don't think that a biopsy adds anything useful. So we only biopsy the ones where there's a diagnostic dilemma, or if the picture's changed, and I'll come back to that. We tend to get a CT scan of the sinuses, and I would selectively consider an MRI if I'm suspicious of complications. I don't do a chest X-ray anymore because the rheumatologist will generally get a CT scan of the chest. So GPA, we want to consider whether the patient needs admission. And certainly I remember from being an SHO, a patient who we saw with Wegener's, diagnosed on a Friday, was dead by Monday by renal failure. So they can deteriorate very quickly. So you want to assess their renal function and consider if you need to start steroids immediately. You want to treat secondary infection because that can also lessen the severity of the disease outcome, so systemic and topical treatments. And Septrin in particular has a very useful effect in GPA, both from its antibiotic and immunomodulatory effects. You want to refer to a rheumatologist, and you want to identify a good rheumatologist and look after them, and they will look after you. And they will take over all the ongoing management of their immunosuppression. And essentially you'll see as a recurring theme, treatment involves steroids, cyclophosphamide or azathioprine, and rituximab has really transformed the care of GPA patients. They need continued follow-up because they go on to have a whole host of ENT problems. Now, in the past, the untreated mortality was greater than 90%, and the average survival without treatment was only 5 months. So that was really pretty dismal. With azathioprine and methotrexate, it improved up to 80% 5-year survival and a 50% disease-free survival. So significant relapse still. But now with rituximab, and they have almost normal life expectancy and a reasonable chance of disease-free survival as well. Here you can see scleritis, a middle ear effusion, saddle nose. You can see the subglottic stenosis. We've had a few patients with quite severe subglottic stenosis going through pregnancy who have needed a tracheostomy to cover delivery, just because everything tends to flare up a bit. You can get facial palsy. So we need to be actively involved in the ongoing management for any of the complications of disease. And I think we play a useful role in monitoring disease activity as well. The rheumatologists will often ask if they think a patient's having a flare-up for me to have a quick look in the nose. Here you can see a nasal cavity. This is the skull base. This is going up into the frontal sinus. It all looks pretty awful. But after, you can see how normal mucosa, this is the frontal lobe covered with a very thin membrane. There's a large meningoencephalocele seal, but actually it all looks pretty healthy. So this is now a patient who is in stable remission, and we can reconstruct her nose, and we'll come back to that later on. We need to offer supportive therapy to help them with their nose, so douching and lubrication is really important. I use a combination of nose oil, which is a sesame oil nasogel, and glucose and glycerin, which is a really useful product that you can get from Lloyd's Pharmacy and other over-the-counter stores. It's a really sticky solution, but it actually reduces crusting quite well. I tell patients to add Johnson's baby shampoo into their douche because that will help break up the Staph aureus biofilm, and we can use steroid rinses and Bactroban as well. You certainly want to avoid any surgery in active disease. If I do have to operate on the sinuses, I give perioperative steroids and continue for at least 2 to 3 weeks afterwards. And I would certainly want to see stable disease for at least 12 months before any septal reconstruction or repair of a saddle deformity. And if the picture fails, and certainly if our rheumatologists think that condition isn't being treated as they would like, they will often ask for a repeat biopsy to see if there's anything else going on, or perhaps just a review to look at endoscopically what's going on in terms of disease activity. And I'm always reminded of this guy. This is another patient I met in my first year as a consultant. He was 48 at the time, and he was referred having had a turbinate reduction. And the history was that he had initially presented with crusting and nasal obstruction and had gone on to have an operation called a degloving of a turbinate. And essentially you take off the mucosal surface of the turbinate and hope that it will re-heal. I don't think it's performed very often anymore because it often didn't re-heal. But this patient just simply didn't heal at all, and he had thick crusting over this denuded bone. But it turned out that although he was ANCA negative, we took a biopsy and it turned out to be localized GPA. He responded very well, was treated with prednisolone, converted onto methotrexate, and having been stable for a few years, I discharged him. So I was a little surprised to walk past him in the corridor a couple of years ago with this very swollen left eye, and chatted to him and asked what was going on. And he told me how he was having an acute flare-up of his GPA. but unfortunately it wasn't responding to treatment. He was now on rituximab and having high dose methylpred. And he'd already had a biopsy performed by another team that had come back showing GPA. So these are his scans, and what you can see is now there's a soft tissue mass that extends into the orbit. So you can see thickening of the inferior rectus and this soft tissue density here. And pseudotumours are quite common in GPA, so it could simply represent severe disease. But I spoke to the rheumatology team and we agreed that we would get another deep biopsy. Here you can see him after his chemotherapy. Unfortunately, he had transformed into an NKT cell lymphoma, and we could only get the diagnosis by taking a deep biopsy from in the orbit. So you've got to take the biopsy from the right point. And we then went back and reviewed the biopsy that it had before, and actually looking at it closely, it showed both lymphoma and GPA. Now, the pathology request form, the clinician had written query GPA on the request form. And so the pathologist quite rightly looked at the slide, saw granulomas and said, yes, GPA. And the pathologist was really quite distraught and admitted that they had been misled by this question, you know, could this be GPA? Well, yes, it definitely is. And that really biased their reporting. And so it's really important to give the right information to the pathologist, you know, known GPA, now failing to respond to treatment, has the picture changed? And we probably would have got a different answer on that early biopsy. It probably wouldn't have changed the outcome. It was a very aggressive tumour. But it always reminds me that certainly if the rheumatologist asks me to biopsy, if the mucosa is normal, I will say no, but in pretty much every other case, I will say yes. So key points before we have some questions: never operate on a crusty turbinate or septum. Do take a biopsy if you're not sure, and it really highlights the importance of having a good team approach with your rheumatologists and being receptive when things aren't going as well as you hope. Any questions before we carry on?
So we've had a few questions coming in through the chat function, but actually Mr. Bala and Mr. Nix have been very helpfully answering as we go. I might take advantage to ask one. The more subtle presentation of a crusty perforation that might be bleeding is quite a common one that we see in clinic. Would you then consider biopsying all septal perforations? And if so, would you do that in clinic or in theatre?
So I think, you know, at the first presentation, I'll do bloods, ESR, CRP, ANCA, other autoantibodies. I will give them a course of triple therapy to see if that heals over. But if when they come back, there's still that unhealthy crusting edge, then I would take a biopsy. And certainly with the septal perforation, it's quite amenable to taking a biopsy in the outpatients.
And by triple therapy?
Fusobet, Bactroban and Naseptin in rotation.
Perfect. That's lovely, thanks.
So moving on, we're going to think about other causes of a crusty nose. This is a particularly pleasant view, but something that again would make you suspicious that there is something else going on. And I think by far the most important differential and the most common differential that I see are cocaine-induced midline destructive lesions. So in almost all respects, they mimic GPA, apart from they are very much centrifugal destruction of the nose. So more often than not, patients will deny cocaine use. The biopsy often is not particularly helpful. If they have a palatal fistula, that's essentially pathogenomic. There have been 5 reported palatal fistulas in patients with GPA, but if you look very carefully at the literature, actually they were probably all cocaine users as well. And it is exceptionally rare to get a palatal fistula in GPA. So if you see that, certainly that's highly likely to be cocaine. The other thing is they get severe pain, much more so than I've seen in a patient with GPA. And unfortunately, the pain then leads to a vicious cycle because they carry on using cocaine for the pain relief and everything tends to get worse. Certainly it's much worse if someone is mixing ketamine with cocaine, and there seems to be a genetic predisposition. You know, there are hundreds of thousands of people that use cocaine without their nose falling apart. And we do see people that I think genuinely have used it once or twice and everything disintegrates. So we don't yet understand why some people have a much more severe destruction than others. And there's some talk about whether it's related to what the cocaine is cut with, something called levamisole, which I think is a veterinary antifungal agent, can be used to mix cocaine, and that really causes nasty things along with vasculitic skin lesions. And the treatment really is to stop cocaine, and there isn't an alternative. Unfortunately, that's the one bit that's very difficult to achieve. Other differentials, sarcoidosis, more common in black patients rather than Caucasians. I apologise for the spelling error there. It affects the lungs, lymph glands, skin, heart, central nervous system. You tend to get these jelly nodules in the nose, or skin changes lupus pernio. I see this much less frequently, but typically with lupus pernio rather than chronic rhinosinusitis. But again, it's one of those things that you just need to be suspicious for. So you get these lesions on the outside of the nose, lupus pernio changes, and these can be quite disfiguring. So patients really don't like this. It looks like some awful growth, and they find it quite unpleasant. You can treat it with hydroxychloroquine. Donald Trump would be proud. It's one of the few conditions where it actually is really useful. Topical steroids are intralesional steroids, but you have to be careful with intralesional steroids because they can cause a loss of pigmentation. So you might have to balance that. TNF inhibitors now have become very useful in this condition of really transformed care. So here you can see the sort of after effects of an area of lupus pernio, again, very disfiguring and very difficult to treat. Churg-Strauss, I think of all of them, is actually the most difficult to pick up. Essentially, it's vasculitis which presents with a prodrome of asthma, chronic rhinosinusitis with polyps with early recurrence. And so they can be like any patient with type 2 inflammation. They often have eosinophilia, as do most patients with type 2. So you have to really keep asking the question in a patient with difficult to treat polyps who isn't responding. We diagnose it based on the asthma, eosinophilia more than 10% in peripheral blood. So if your eosinophil count goes over 1.5, certainly that's highly suggestive. Anything over 10% of the total white count raises questions. Pulmonary infiltrates, and you can diagnose it on granuloma, but often it only gets picked up when they have an acute crisis. And the problems with these patients is they have a very high risk, a very rapid deterioration leading to cardiac death. They have a vasculitic stage where they fall off the cliff very quickly. I was involved in a medical legal case where a patient had been tested with ANCA, ESR, CRP on multiple occasions over a 10-year course, had been relatively stable, and then over a course of a weekend had a cardiac arrest, infarcted his bowel and died. And the family tried to sue for a failure of diagnosis, and it had been looked for at every stage. The clinician couldn't have done more, but it shows how difficult it is to pick up really until things go wrong. You might get a few giveaways on the CT scan, and here you see this very extensive osteitis, almost sort of a double line in the sinuses, tram lining. So if you see this in the patient with polyps, it might be a sign that there's something else going on. And we all miss it. This is a patient who was under my care. She was the wife of one of my respiratory colleagues, so I know the family very well. She had very difficult to treat asthma nasal polyps. She had optimal medical treatment. She had surgery with good post-operative steroids. Again, she recurred early. At every point, her ANCA was negative. She had none of the other signs. Her eosinophil count was always at the upper end, but never over that 10% level. And she was doing poorly, so we decided to start her on Dupixent, which is an anti-IL-13 monoclonal antibody. And mepolizumab typically suppresses eosinophils, but Dupixent, when you start it, you often get a surge in eosinophils or a transient hypereosinophilia. Now, because her asthma improved, we were able to reduce her steroids. And this seems to be very common. So a lot of cases of EGPA are picked up when you get any reduction in steroids. It might be because you've started montelukast or another leukotriene antagonist, or you've done something else that otherwise improves their care, and then you drop the steroid dose. And she was admitted with an acute hypereosinophilia, severe headache, malaise, and turned out to have converted into full-blown vagus, EGPA or Churg-Strauss. So they are very difficult to pick up, and you just have to keep asking the question. A few other conditions, IgG4 related disease, we're starting to see a lot more of, really because our pathologists are looking for it and picking it up much more effectively. And again, it can affect almost any organ. And it causes an inflammatory fibrosis, so lots of scarring, this thick fibrotic condition. Here you can see in the turbinates and causing adhesions. It has now replaced what we used to call eosinophilic angiocentric fibrosis. And again, it's treated with steroids, azathioprine, rituximab. You can see the theme, but it can present in lots of different ways. So this was a patient who had been treated elsewhere with recurrent frontal sinus symptoms. You can see that she's had a Pott's puffy tumour and a frontal stent put in. She was only referred to me when on her 4th operation, it was thought that she had a CSF leak. So she was referred up for repair of the CSF leak. And what was interesting was by the time I saw her, the CSF leak had healed itself because the whole of the nasal cavity was filled with this really intense fibrotic reaction. And here I've had to divide adhesions between the lateral wall and the middle turbinate. and this dense scar tissue going up in the frontal sinus. And by the time I got up into the frontal sinus, it looks a little bit like a dog's dinner because there was all this really thick scar tissue everywhere that I had to cut through. So when anything looks abnormal, we send off a biopsy, and this came back as IgG4 disease. And so with steroids and now immunosuppression, we've managed to keep the frontal sinus open. So again, this wasn't necessarily a surgical failure that she kept stenosing, but the underlying condition that hadn't been picked up. Here's another case. This was a young lady who was listed by junior for a septoplasty, and the surgeon met the patient on the day of surgery. And indeed, if you look into the right side of the nose, there appears to be a deviated nasal septum. But when you look into the left side of the nose, there also appears to be a deviated nasal septum, and there's this huge midline swelling of the septum that you can see here on the MRI scan. And so I thought initially it was Rosai-Dorfman disease, which is a histiocytosis. And my standard approach for those patients is, at the time of biopsy, to basically denude one side of the septum down to cartilage and take all of that area off and send it off for histopathology. And in fact, it came back as IgG4 disease. Here you can see the PET scan after I've done one side of the septum and the rest of the septum lighting up. And then once the septum's healed, I go back and do the other side. And this is the sort of healing stage as I take the patient back to theatre to clear the other side. And it's actually remarkably effective. And I think doing it one side at a time, I've avoided any septal perforations in a series of about 10 patients. Then there's lots of weird and wonderfuls. Now, I have never seen a patient with leprosy, syphilis, rhinoscleroma or spirochetes. I've had to pick pictures up from the internet for all of those. I've had one patient with TB in the nose. So I looked in the nose and saw this fungating lesion on his turbinate, which turned out to be TB. But it's very rare. Myelofibrosis, again, I've only seen it once. It is extremely rare. It's basically a foreign body reaction to petroleum-based products. This was a young lady who had had a petroleum Gelinet pack put in the nose after FES, and it had caused this really intense inflammatory reaction on the turbinates, which had progressed to basically obliterating all of the nasal cavity. And you can see all of these little globules of petroleum in the histopathology tissue. So very rare. But I avoid Vaseline in the nose post-op, particularly if there's been any breach of the lamina papyracea. You don't want the Vaseline to get into the orbital fat. And the one that we really don't want to miss, non-healing midline facial granuloma, which we now know is a T-cell lymphoma. It is exceptionally rare, but you've got to get a good representative biopsy, and you need to give the pathologist the right information so that they don't miss it. So how do we manage the complications? ESAM Alabide has really transformed my surgical treatment of large septal perforations. Here's basically a subtotal septal perforation. Here's the columella. That's the back of the nose. There is absolutely nothing in between, and it's about 2 to 3 centimetres in height. And certainly before spending time with ESAM, I would never have attempted repair. But he has a really good, reliable technique that I will now attempt to repair most perforations, provided I'm absolutely confident that the patient's granulomatous disease is stable or they're free of cocaine. And essentially you take a flap from the whole of one side of the nasal cavity, from the posterior choana right up, including the middle turbinate if it was still there. You bring it right out to the front of the nose, right to the front of the perforation. And you raise the whole flap off the floor of the nose, but you keep it attached along the inferior aspect of the septal perforation. So this works really well if you've got a long oval perforation, because this becomes your vascular pedicle. And essentially you take your flap and you roll it up and you pull it through to the other side. You freshen the edges on this side of the perforation so that this flap will sit here and heal to the edges on the opposite side. So this shows you the floor of the nose. You can see I've made the cut all along here. I've taken all of the mucosa off the floor. Here it is as I've rolled it up. So this is now pulled through to the opposite side of the nasal cavity. And here you see what was on the bony surface of my flap, and that's exposed but will re-epithelialize. On the opposite surface, on the opposite side of the nose, I've got a nice epithelialized mucosal surface. So this is my flap in place, really filling the whole of that septal perforation. It's got a very long pedicle, and it's quite a robust, chunky flap. I apologise, I haven't got post-op pictures, but my success rate with large perforations using this technique has gone from certainly less than 50% to over about 80%. And I saw a lady this morning in clinic, still a little bit of crusting on this exposed side, but nice and robust healing flap 6 months later. So you can close really quite large perforations. If I'm not confident that the patient is stable or that they've stopped using cocaine, these little Blom-Singer septal prostheses have really transformed my practice. They have a little magnet, so they come in two parts. They're very thin. You slide into each side of the nose and the magnet just clips into place and holds them in the perforation. You can put them in outpatients without a local anaesthetic. It takes about 30 seconds to fit them. And the nice thing is they come in 12 different sizes. So you can measure up nicely with a little ruler and get the button that fits perfectly. And patients find them very comfortable. So that can avoid surgery in the majority of cases. I've never really had any success with septal buttons before finding these, but these are tolerated and work very well. In terms of nasal reconstruction, this is a young girl who was going off to university but still had active vagueness, and she desperately didn't want to start her university career with a saddle nose. So this is someone we treated with a little bit of injectable filler. And you can see it's not perfect, but it's actually filled in the dent quite nicely. And we topped it up every 6 months until she was ready to have reconstructive surgery. So there are some temporizing measures that you can do in someone with active disease if, from a cosmetic point of view, it's really important. This is the lady I showed you before, and this is her after a conchal cartilage reconstruction. And again, from a side view, you can see significant saddle deformity, and you can fill that in very nicely with just conchal cartilage and a little bit of permacol overlay. And then for more severe defects, and I apologise for the quality of the pictures, this is a gentleman who was a taxi driver who had lost all of his piriform aperture, so that this part of the nose had basically fallen in on itself. And he didn't have functional nasal obstruction because he had a huge subtotal septal perforation, but he was finding it very difficult to get work because he would be on the driver's side and people would look at him and they would basically walk away from the taxi. So when you've got a very large defect, you're going to need more than a little bit of conchal cartilage. So this is a patient that I took rib in. This is a mid-facial degloving technique with a septal strut put into what was left of the columella with some rib. We put some diced rib in that alar margin to fill out the area there so we could get a little bit more support on the face. And then we took a complete composite graft from the ear. And this was a really nice technique that my plastic surgeons taught me. So you take a full thickness graft, skin and cartilage from the conchal bowl, and then you can basically pull through some skin from the back of the ear. So this skin was raised up, kept on a pedicle anteriorly, so that when you put the ear back down, you can pull it through and fill the defect, and that heals very nicely. So, apologise if I run over time, but just to recap, our job as ENT surgeons is really to focus on this one, make sure we don't miss granulomatous disease. So it's just something you need to keep thinking about if the appearance doesn't look quite right. We can certainly go a long way with helping with the diagnostic workup. We need to direct patients to a rheumatologist to manage their disease, and we need to work very closely with them. We need to help them with monitoring disease, and we need to treat and support complications of the disease. If something looks a bit weird, it probably is, so take a biopsy. If something looks normal, it probably is, so don't take a biopsy. Think about weird and wonderful conditions every time you see a patient who's not responding as expected. Never operate on a crusty nose or septum unless you need a biopsy or you want to practice learning to close very large septal perforations, and find a good rheumatologist and look after them really well. Thank you.
Thank you very much for that. I think we've got a few people who would like to close some septal perforations inspired by your description of the flap. First question, would you prefer the flap that you described to the Haddad flap?
So the Haddad flap is a nasal septal flap. So if you've got a large septal perforation, by definition, you haven't got a Haddad flap to use.
And the second question, just practically, when you're securing the flap, what suture do you use to secure the flap? So,
I mean, you can pull the flap through and just secure it with a single suture right at the top front edge. I tend to put 2 or 3 in, but it doesn't take much to hold it in place, and I would use a Vicryl or Vicryl repeat.